Hello everyone, today we would like to share this interesting case of an intumescent white cataract who was planned for a femtosecond laser assisted cataract surgery with toric intraocular implantation. The femtosecond laser went according to plan. A quick glance at the capsulotomy at this stage doesn't reveal any problems. The anterior chamber is opened. The anterior capsule should be stained with tryphan blue dye in such white cataracts. When the tryphan blue dye was washed, notice carefully at the inferotemporal location. What do you notice? There is an extension or the runout of the capsular axis. And there we have the Argentinian flag sign in a femtosecond laser assisted capsulotomy. The remaining capsulotomy is now completed with a microforceps. However, why did this happen? Although flax is known to eliminate the risk of rexus runout in intumescent white cataracts, however, this is not the case all the times, as you can see. A femtosecond laser capsulotomy is made up of thousands of small dots that are connected to each other. So instead of a manual continuous curvilinear capsular rexus, a femtosecond made capsulotomy is weak. At this stage, however, the learning points are to not panic. Fill the chamber with viscoelastic and assess the situation. If you don't notice any ominous signs like the pupillary snap sign or the sinking of the nucleus or the fluctuation of the anterior chamber, you can safely proceed with phacoemulsification. However, there are a few considerations to be made. Lower the vacuum settings, lower the fluidics, lower the aspiration flow rate, and do a slow motion low fluidics phacoemulsification. Even during the chopping maneuvers, as you can see here, the horizontal chop is being performed very gently. The chamber is to be filled with viscoelastic and aim should be to avoid chamber fluctuation. Remember, viscoelastic is cheaper than the vitreous. Did you notice something here? The hydrodissection was avoided in this case. Avoid hydrodissection in white cataracts anyway because you don't know what the posterior capsule status is like, and especially in a compromised rexus, hydrodissection is to be avoided and nucleus rotation is to be avoided. Gentle nucleus rotation can be done during phacoemulsification as and when required, and during these chop maneuvers, make sure that the lateral separation is not too much because it puts pressure on the already compromised bag and the zonules. Such cases test your patience, so just be calm and continue with the case. Notice the slow, gentle rotation of the nucleus. During the phacoemulsification, make sure not to capture any of the capsular rexus tags in the phaco probe. Be careful while eating the last piece of the nucleus. Keep the chopper in the safe position so that the PC doesn't end up coming in the phaco probe. Fill the chamber with viscoelastic. Cortical aspiration now becomes another critical step. Begin irrigation and aspiration from the quadrant where the capsular axis is intact. Avoid pulling the cortex towards the radial extension as this may propagate the tear into the posterior capsule. Again, during cortex aspiration, use low fluidic settings, reduce the bottle height, reduce the vacuum, reduce the aspiration flow rate, and be very gentle with the capsule and make sure not to pull the capsular axis tag into the aspiration probe. Common question in these situations is whether a toric intraocular lens can still be implanted. The answer is yes, provided the capsular bag remains stable and adequately supported. Patients can be counseled that there is a theoretical possibility of the postoperative IOL rotation because of the incomplete capsular axis. Fortunately, this is uncommon when the viscoelastic behind the intraocular lens is completely removed before the conclusion of surgery. As you can see here, we have a continuous axis for most of the part and the bag appears to be stable. So we proceed with implantation of the toric intraocular lens. Here it goes. Be sure to implant the lens very gently. Even if the lens opens in the anterior chamber, that's fine. Just tuck in gently into the capsular bag. Despite the intraoperative unexpected complication, the surgery is completed successfully. The side port incisions are then hydrated, followed by intracameral preservative-free moxifloxacin. The final message from this case is simple. Complications are inevitable in cataract surgeries. Outcomes are determined not by the complication itself, but by the decisions made immediately afterwards. Recognizing the problem early, respecting the zone use, maintaining chamber stability, minimizing stress on the capsule, and adapting surgical technique can transform a potentially difficult case into an excellent visual outcome. On the first postoperative day, the toric intraocular lens is well centered and perfectly aligned and stable within the capsular bag. The patient achieves an unaided visual acuity of 6/9, demonstrating that an Argentinian flag sign does not necessarily predict a poor surgical outcome. Thanks for watching.